If you can hear me. Clap twice if you can hear me. Outstanding. Good morning. How is everyone? Good. Welcome. Thank you all so much for being here. I am Senator Angela Williams Graves, and I want to take the opportunity to welcome you to the Black Maternal Health Legislative Summit. A lot of you have come from near and far because this topic is of great importance to you, and I just want to say thank you on behalf of the entire Maternal Health Caucus and all of my colleagues here that are assembled between the House of Delegates and the Senate. We thank you for your presence, we thank you for your interest, and we thank you for your input. Before we get started this morning, a couple of things. Number one, I went through and I just wanted to take a look. I kind of like definitions sometimes, and I looked up the word maternal. And maternal means relating to, belonging to, characteristics of a mother. And then health. What does health mean? The condition of being sound in body, mind, and spirit. A condition in which someone is thriving or doing well. And putting those two words together, I think, defines why we are here today, to ensure that every mother, before, during, and after birth, is in a condition of sound body, mind, and spirit, and that they are thriving and doing well. So with that in mind, I'd like to take the opportunity. We've got a great panel of speakers this morning, but we also have some out-of-state guests that I would like to acknowledge before we get started. We have Representative Marilyn Lands from the Alabama House of Delegates. Will you stand? Representative Vivian Flowers from the Arkansas House of Representatives. Thank you. Will you stand? All right, she hasn't arrived yet. All right, and can y'all just hold the applause until we get done with everyone? Senator Tracy Davis, the Florida State Senate. Representative Felicia Robinson, Florida House of Representatives. They were here, okay. Representative Park Cannon, the Georgia House of Representatives. Senator Regina Barrow, the Louisiana State President Pro Tempore. Here she comes, right in the back. All right. And Senator Arthur Ellis, from the Maryland State Senate. Delegate Jennifer White Holland from the Maryland House of Delegates. Representative Mary Frances Clardy from the Minnesota House of Representatives. Representative Latisha Jackson, did I get that right? Latisha? Okay, from the Mississippi House of Representatives. Representative Diamond Staten Williams from the North Carolina House of Representatives. That's a good solid last name, Ms. Williams. Representative Juanita Brent from the Ohio House of Representatives. And we have joining us virtually Representatives Morgan Cephas, Gina Curry, and Latasha Mays, co-chairs of the Pennsylvania Black Maternal Health Caucus. They will be joining us virtually. In addition, we have Senator Tamika Devine from the South Carolina State Senate. We have Representative Annie McDaniel from the South Carolina House of Representatives. And we have Representative Tony Rose from the Texas House of Representatives. We also have former State Representative Jamie Belsey from Massachusetts. Did I get everyone? Welcome. Thank you so much for being here. We hope to have a great conversation and show you all some good Southern hospitality. Now, without further ado, we will move on in our program. We have dynamic speakers that I am certain are going to leave you inspired and provide you with information. Our first panel is going to include Senator Eloise Lucas, who is the Senate President pro tempore, and the first Black female to be chair of the House Finance and Appropriations. Senate Finance and Appropriations. I'm sorry. I'm a former House of Delegates member, so forgive me. And then we have Speaker Don Scott, the first Black Speaker of the House in the more than 400-year history of the Commonwealth of Virginia. We have Senator Mamie Locke, who is our Senate Caucus Chair, and Representative Bobby Scott, who represents the 3rd Congressional District in the United States Congress. Senator Lucas.
Good morning. Last night I had the distinct pleasure of welcoming all of you to what I thought was going to be a reception, but turned out to be one of the best soul food dinners I've had in quite a long time. And I'm still applauding Candy for that. I almost took a piece of that chicken with me when I left last night. But look, I'm here to welcome you again this morning and to tell you how delighted we are to see so many of you come from all across the United States to be here with us, because this is an extremely critical issue and topic that we're about to deal with. And Delegate Candy King Monday asked me to share with you my life story, and I told her I forgot it. And she told me that she had captured me on tape saying to some people why maternal health is so important to me. I am fortunate in that I've been blessed to have been the first in so many things and have been successful, but it was because I had supportive family and friends behind me. Because to have a child at 14 years old in the 8th year, your 14th year, meant that I was pregnant at 13 and didn't know it. And it wasn't until my parents took me to the doctor to find out why I was filling out so fast that we realized that I was pregnant. So I was a 14-year-old high school dropout. And by the time I was 21, of course, I had 3 children, but by that time I was married. But maternal health has been extremely important to me, and especially when it has to do with teen pregnancy, because of my own personal life story. So, I thank God every morning that I wake up for having gone back to school and completed my high school and gone to college and gotten 2 degrees and become the first woman apprenticeship fitter and come to the Senate only as the second African-American woman to ever serve in the Senate of Virginia, to come as the first African-American to be President pro tem in the 405 years of this Commonwealth and chair Senate Finance. A lot of milestones along the way. That's the reason why this issue is so critically important to me, because I understand how important it is for us to have Black maternal health care, and especially as it deals with pregnant teens. And so much can and will be said here today, so I'll just stop here since I've committed my assignment to Delegate Candy King, in telling you why this issue is so critically important to me. And again, I welcome you all, and I'm looking forward to all of the good news that we're going to hear from you and how we approach this. But I want to end by saying that there's one thing that I hope that we will all consider during this process, and that is to address the racial disparities and implicit bias in healthcare. I want us to implement mandatory ongoing training for healthcare providers to assess, address, and reduce implicit bias and racism in medical settings. And if we can accomplish that, in addition to all the other things that I know you will do, I will leave here feeling fulfilled. Thank you.
Good morning, everyone. I'm Don Scott, current Speaker of the House here in the Commonwealth of Virginia. Every time I hear it, it sounds funny coming out of my mouth. But God is amazing. It's my honor to welcome everyone to the Black Maternal Health Legislative Summit. I'm proud to join Senator Lucas, and you can hear she is an amazing leader, and the Virginia Black Maternal Health Caucus in hosting you today. I'm glad to see each of you here. I'm looking for my one special guest who's supposed to be here, my wife. She'll be participating today, the brilliant Dr. Melinda Colson Scott. She'll be participating in the panel later today, so I'm proud that we're in this role so we get to promote this issue and put it in the right light that we have neglected for so long. Black maternal health is a complex issue, but our mission today is simple. Work together to figure this thing out. Too many black mothers and babies are dying and suffering irreparable physical and mental damage due to broken systems and lack of resources. Virginia's made great progress due to many of the people in this room. While I'm proud we've expanded access to care, this crisis remains urgent, especially in rural communities. By being here today with the legislators from across the Commonwealth and the country, we're sending a clear message of our shared commitment to addressing this crisis once and for all and ending the health disparity black women face before, during, and after childbirth. The truth is stark. Black women in the United States are more than twice as likely to die from pregnancy-related causes as other women. Those are my mothers, sisters, and daughters. This is who we are losing. As the overall maternal mortality rate has risen in recent years, the disparity has grown wider. In the aftermath of Roe v. Wade being overturned, these challenges have been compounded. So now, black women in southern states with restrictive reproductive health policies face even more significant barriers to care. It's wrong. Let's not kid ourselves either on this. Systemic racism is at the heart of this crisis. Whether it's economic status or bias in the healthcare system, these stresses exacerbate maternal health outcomes, making it that much harder for black women to have healthy pregnancies and deliveries. But there is hope. All of us being here today is hope. To truly address this crisis, we need more research. We need more technological solutions. We need more advocacy and policy and community partnerships. It's essential that we continue to push for better data and innovative solutions that address the unique challenges black women face in our healthcare system. Together, we can build a future where every woman has access to care and the support she deserves. This issue is personal for me, not only for my wife, but I have a 15-year-old daughter. I never thought that I would live in a country where my daughter would have less rights than my 89-year-old mother, but that is where we are today, and so we must continue to fight. As we continue to have these conversations, I'm hopeful that we can shape policy to reduce these disparities, improve healthcare access, and promote quality care for all mothers and children across the Commonwealth. We have a shared responsibility to ensure that no mother dies giving life. And with your continued support and collaboration, we can bring about real and lasting change. So thank you once again for your commitment to this critical issue. Let's leave here today energized, united, and more determined than ever to create a Commonwealth and country where every birth is a cause for celebration and not a time of fear. I'm confident that together we will make a lasting difference. Thank you and welcome to the Commonwealth of Virginia.
Good morning.
Good morning.
Y'all not happy to be here? I'm Amy Locke, and I represent the 23rd Senate District, which is in Hampton Roads. And I heard somebody was here from Mississippi. I'm originally from Jackson, Mississippi. And I want to thank you all for being here with us this morning because we have a lot of work to do. Because every 7 seconds, a woman or newborn dies or a baby is lost to stillbirth. Most of these deaths are preventable with quality health care before, during, and after childbirth. I have friends who have suffered multiple stillbirths, family members who have dealt with children born prematurely, and having babies in NICU for months. My own sister nearly bled out because the doctor walked away after her child was born, not understanding that he left the umbilical cord inside. But for the nurse, she would not be alive today. So that's why we're here today to discuss those kinds of issues. We also know that Black women are more likely to have medical conditions such as diabetes and endometriosis that might impact their ability to get pregnant or carry a baby to term, but doctors sometimes do not advise them of the possible barriers to conception. Black women also develop fibroids at a higher rate, 3 times higher than white women. In Our Own Voices did a poll that they commissioned ahead of the 2024 election cycle. And that poll revealed that nearly 1/4 of Black women aged 18 to 24 worried about their health and safety during pregnancy or childbirth because of their race. Almost 40% of those women feared death if they got pregnant. That fear is a reasonable one, as states are already undermining the Federal Emergency Medical Treatment and Labor Act that protects people with life-threatening emergency, including pregnancy-related crises. These concerns are valid, also with issues raised in Project 2025 that it would impact maternal health and pregnancy care. Without timely access to culturally affirming care, Black women are more likely to not receive routine screenings and treatment for chronic conditions, which increase their risk for injury and death during pregnancy and childbirth. But even when services are available and covered by insurance, providers may lack cultural training to serve Black women appropriately. That's why we're here today, to pull that scab off and to talk about these issues and to talk about ways that we can begin to address these in a way that's meaningful and to begin to come up with solutions. So I want to thank you all for being here so that we can start to pull together solutions. So again, thank you.
And our last remarks will come from Congressman Scott.
Thank you. Thank you, and it's certainly a pleasure to be here with all of the legislators. My colleague, Jennifer McClellan, I believe, will be here. I want to thank Senators Kaine and Warner for their good work. And it's good to be here in the General Assembly building. Some may note that my first year in the General Assembly was the first year we moved into the brand new General Assembly building. That, of course, is the one they tore down to make room for this nice facility. Many years ago, when I was in the General Assembly, I chaired the Virginia Task Force on Infant Mortality and served the Southern Governors Association, established the Southern Regional Task Force on Infant Mortality. And so this is obviously a problem that's been going on for a long time. Now, we all know what the problem is. The United States has the highest maternal mortality rate of any developed country. Maternal death rate in the U.S. Is more than double that of other comparable countries, and that rate for Black women is much higher than for white women. And according to the CDC, the problem is getting worse. And we know the majority of pregnancy-related deaths are preventable. So we're not here to celebrate the problem, we're here to solve the problem. And first, we know that insurance coverage is going to be part of that solution. Before the Affordable Care Act, only 9 states required coverage of maternity care, and only 12% of individual market plans provided that coverage. But now, thanks to the ACA, insurance for individuals and small businesses must cover maternity and newborn care, giving mothers the care they need. And expansions of the ACA under the American Rescue Plan Act and the Inflation Reduction Act, and Virginia's expansion of Medicaid, thank you, members of the General Assembly, all mean that a higher portion of our population has health insurance today than ever before. And we need to make sure that that insurance becomes even more affordable and that we continue to reduce the cost of prescriptive drugs. Additionally, my colleagues in the U.S. House and Senate are working to pass the Black Maternal Health Omnibus Act to address maternal health crisis through historic investments that comprehensively address the drivers of maternal mortality, morbidity, and inequities. The omnibus is comprehensively designed to address the crisis and save moms' lives through a series of bills that, just to summarize, make critical investments in social determinants of health that influence maternal health outcomes like housing, transportation, and nutrition, extend WIC eligibility in the postpartum and breastfeeding periods, provide funding to community-based organizations that are working to improve maternal health outcomes, and promote equity, and increase funding to improve maternal health care for veterans and those incarcerated. It supports moms with maternal mental health conditions and substance abuse disorders. In addition to those, we have to fund doulas, which are especially needed today and will be needed until Black women no longer are subjected to implicit bias and the system fails to properly respond to Black women's needs. And we also need to train up our workforce so that women will be able to find a doctor when they become pregnant. Now, last night I mentioned the problems with dealing with prevention, that you never get any credit. The success happens after the next election. There's no constituency in that, but there is hope. One of the last legislative victories I had as a member of the General Assembly when I was a state senator was my bill that created the Virginia Council on Prevention. That's right, you had a council, all the agency heads, education and corrections, and everybody around the table, so that as you went forward, you would consider prevention as part of the legislative and administrative strategy. So if education wanted to kick somebody out of school, correction to say, whoa, all you're doing is giving them to us. And the council could make those determinations. Now, nobody here ever heard of the Council on Prevention, because the year after I left, they abolished the Virginia Council on Prevention. Anyway, I remain inspired by the progress we have made and optimistic about the progress we will continue to make. And although our work is not over, the focus today is not on the problem, but the solution, and that gives me hope. So keep focused, because we know this is a problem that can be solved. Thank you so much.
Thank you, Congressman Scott, and all of our welcome guest speakers. At this time, we're going to ask Julie Dime from the Virginia Hospital and Healthcare Association to bring us greetings on behalf of the sponsors.
Good morning. I'm Julie Dime. I'm the Vice President of Government Affairs for the Virginia Hospital and Healthcare Association, representing 111 hospitals and the over 126,000 dedicated professionals that they employ across the Commonwealth. Thank you for the opportunity to be with you today as we focus on the critical issue of Black maternal health. In Virginia, childbirth is the leading reason individuals are admitted to our hospitals. For many, this moment marks the beginning of a beautiful journey. For others, including myself, it can present some of life's most difficult, daunting challenges and immense sadness. Maternal health transcends individual experience. It is a community imperative. The well-being of mothers directly influences the health of their children and the fabric of our society. VHA is proud to partner with stakeholders across the maternal health landscape to enhance care and address disparities. I want to take a moment to express my heartfelt gratitude to those of you here today and also the professionals in our hospitals, our physicians, nurses, midwives, doulas, and our community health workers who tirelessly advocate for mothers and families every day. Every woman deserves access to respectful, let me repeat, respectful, high quality and comprehensive prenatal and postpartum care. Yet we know gaps exist. For example, Black women in Virginia confront disproportionately higher risk of complications and maternal mortality. This is why initiatives like the Black Maternal Health Week, recognized annually in the month of April, are crucial. They highlight the urgent need for systematic change. But let me be clear. While we dedicate a week to raising awareness, this is not a topic we can highlight merely once a year. Maternal health requires our unwavering commitment 365 days a year. Each one of us can play a vital role in preventing pregnancy-related deaths and improving maternal health outcomes. By supporting programs that provide comprehensive prenatal and postpartum care, mental health resources, and community education, we empower women to take charge of their health and make informed decisions. Together, And as Senator Lucas said last night, together, let's say together, we can forge a future where Black maternal health is consistently prioritized, where women feel empowered, and where families can welcome new life without fear. VHHA envisions a future where Virginia is the healthiest state in the nation. Achieving this goal begins with prioritizing the well-being of mothers and all women and babies. Thank you for your commitment to this vital cause and for the crucial work you will do today and every day. We look forward to our continued partnership on this very important mission. Thanks for your time.
Thank you, Julie, for your kind words. And I also want to make sure that we highlight all of our sponsors, because all of this stuff doesn't just happen out of thin air. It costs money and it takes time. And so we want to make sure that we thank all of our sponsors: Anthem, Blue Cross Blue Shield, Moms Congress, Centera, the Virginia Nurses Association, FedEx, Sabita Foundation, BMHH Equity, Phillips, HCA Virginia Healthcare Systems, the March of Dimes, and the Virginia Hospital and Healthcare Association, as well as the Black Legislative Leaders Network. So thank you all for your sponsorship of your time, talent, and your dollars. Thank you. At this time, we will get to the heart of the issue. We will call our next two panelists, speakers rather, Raven White from the Maternal Health Advocate. She will present, and then following Raven, we will have Senator Regina Barrow from the Louisiana State Senate. Welcome, Raven.
If you could cue the presentation. Thanks. Good morning, everyone. Good morning. Can you clearly hear me? I stand before you as the CEO of a global event production and luxury lifestyle agency, a former CIA engineer, a consultant, a speaker, a wife, and a mother of two amazing boys. I have multiple degrees. I've been married for years. I'm a member of several organizations, Jack and Jill of America and Delta Sigma Theta sorority. On the surface, I'm a woman who seemingly has it all together. But let me tell you something. Even with all my perceived success, nothing could have prepared me for the battles I faced bringing my two beautiful children into this world. I'm here to share a deeply personal story, one that reveals the often overlooked realities of Black maternal health in America. The first time I became critically ill was during the birth of my son, Bryce. I was 36 years old at the time and thrilled to be pregnant. Like many women, I've always envisioned what my birth experience would be like. I was determined to have a natural birth. So when we discovered that Bryce was breech, I tried everything to turn him. I listened to my doctors, and I walked miles and miles. I went to a chiropractor several times a week, and I even tried some other cultural practices. Yes, I burned sticks on my toes, hoping they would work their magic. I can see my husband's face now, shaking his head, watching me light those sticks on fire. But I was trying to get Bryce to turn. Bryce had other plans. Despite all my efforts and otherwise healthy pregnancy, my doctor advised that a scheduled C-section was the safest option. On August 27, 2015, Bryce came into the world, and let me tell you, it was one of my most joyous moments. The surgery went well. It was smooth. I was awake and aware. I got to see my baby for the first time. The hospital monitored me for 72 hours, and everything seemed fine. My pressure was stable, I wasn't hemorrhaging, and I felt okay. They sent me home with my baby boy, and like so many women, I wasn't fully educated about what could happen next when I got home. I believed I was strong enough to handle the recovery. Even after a C-section, the only thing I thought or was aware of was that walking may be a little challenging for myself as I healed. I wasn't given a pamphlet or a manual for aftercare for myself or things to watch out for. Unbeknownst to me, I was greatly uneducated about what else could occur. The day after I got home, my mother, who was in the audience, who at the time was a nurse with over 35 years of experience at Johns Hopkins Hospital, was staying with me. I remember sitting in my bedroom, holding my 6-pound, 12-ounce baby on my chest and saying, "The bathroom seems so far to go." It felt like a simple comment, but my mother immediately became alarmed. She turned to me and asked, "What did you just say?" Without hesitation, she told me, "We're going right to the emergency room." Now, mind you, I thought I was fine. I didn't feel anything was wrong, but my mother's intuition and decades of experience knew better. When we got to the hospital, the situation quickly escalated. My blood pressure was sky high, 190 over 100. And even though I had delivered my baby, I weighed the same as when I first arrived at the hospital the day 72 hours prior. Something was terribly wrong. After running tests, the doctors diagnosed me with postpartum cardiomyopathy. My heart was failing because my body had taken on too much fluid during the delivery and I was going into cardiac arrest. My heart was struggling to pump the fluid out. If it hadn't been for my mother's quick reactions and actions, I may not have made it. My heart was quite literally on the brink of giving out. That experience was harrowing, but I recovered. I was grateful that I made it through, but that was only the beginning of my journey with Black maternal health. Fast forward 7 years, and I found myself pregnant again at age of 43. After only having Bryce for so long, I was overjoyed to be having another child. This time, I was armed, or so I thought, with knowledge. And I knew that what happened the first time, and I was very upfront with my doctors about my medical history. So I found a new OBGYN practice, one I felt was more progressive and engaged. Because of my previous experience and my age, they referred me to a maternal fetal specialist, and I was heavily monitored throughout my pregnancy. Twice a week, I saw a specialist, and once a week, I saw my OBGYN. For the most part, everything seemed fine. Again, the recommendation was for a C-section, which I went along with, trusting my doctors. But at 35 weeks and 4 days, everything changed. I went in for a routine appointment with the specialist, and my mother was again with me. During the visit, my blood pressure started creeping up, 160 over 90, then 175 over 100. The nurse practitioner calmly told me to go straight to the hospital. She said, "Don't worry. Just go to the maternity ward and I'll let them know you're coming. And make sure you eat before you go." I didn't think much of it at the time, so I grabbed a sandwich and we headed to the hospital. When I arrived, I was relieved to see my OBGYN was on call. It made me feel like everything would be okay this time. But soon after, the doctor said, "Raven, we're going to deliver the baby today." Everything seemed to happen quickly. Once I was prepped for the C-section, things took a frightening turn. The anesthesiologist tried not for 5 minutes, not for 10 minutes, not for 30 minutes, but for 60 full minutes to administer an epidural. I was alone, and I was sobbing. My husband wasn't allowed in the room, My mother was in another room. I was completely alone. The pain was unbearable. I prayed and I thought, this is how I'm going to die. Over and over again, they tried and failed to get the epidural in. I could hear them talking about putting me to sleep, but because of the sandwich I ate on the way to the hospital, they hesitated. That small piece of advice to eat caused a chain reaction that led to me being in excruciating pain for an entire hour. Eventually, they did put me to sleep, but by then, I had endured so much that the baby was in crisis. I didn't see Dawson, my second son, for 5 days. After the surgery, I was rushed to the ICU with dangerously high blood pressure. I spent the first 5 days of his life fighting for my own. Dawson was born healthy at 5 pounds, 12 ounces, but his mother was struggling to survive. My story is not unique. It's a story that reflects the experience of so many Black women who navigate maternal health challenges. Despite all my education, despite all my success, despite all my access to quality care, I literally lost my life twice. Why? Because of the lack of communication between doctors, because of the assumptions made about my strength, because of the gaps in our healthcare system. If the fetal maternal specialist hadn't told me to eat or discuss plans with delivery with my doctors on call prior to telling me to eat, then maybe I wouldn't have had to endure 60 minutes of pain from the epidural not going through. And they may have put me to sleep much sooner if I had an empty stomach. I shouldn't have had to have my pain tolerance tested to that extent on June 27th, 2023, a year ago. Black maternal health is not just a statistic, it's a reality. A reality that we must confront with urgency, with compassion, and with accountability. I survived, but many others don't. Comprehensive medical care is vital. Communication between medical staff and teams is imperative to patient care. And that is why we must keep telling these stories, despite me crying every time I get to that part. Demanding better care and ensuring every Black mother has a fighting chance, not just to survive, but to thrive. Today, I'm grateful that Sheila's daughter, Jimmy's wife, Bryce and Dawson's mother is still here to tell her story. So thank you.
Thank you, Raven, for sharing your story with us and sharing your transparency. We'll now call up Senator Regina Barrow from the Louisiana State Senate.
Good morning. You know, it's always really different when you are in the Senate and you're on this side of the podium. I'm used to being on the other side. I had no idea that that story was going to really bring back a lot of my own personal memories because, Madam Pro Tem, for a long time, I actually suppressed what I went through. It wasn't until this issue really began to become a focal point more and more after the decision that it began to rise up. And the more I try to suppress it, the more it began to rise up. Next month would make 40 years when I gave birth to my daughter. I was 18 years old. And I, too, pushed through to not become a statistic. I was born in Woodville, Mississippi. My parents moved to Louisiana when I was 5. And every year, until I turned 12, we went to Mississippi. So one of the things that my mom wanted to make sure was that her children would be successful, my mom and my dad. And when I became pregnant, I never forget how disappointed my dad was, and he cried like a baby. So I was really determined to go to school and to finish. I could not even attend I couldn't attend my graduation. I was 3 months pregnant and was bleeding, and they did not know why. So they sent me home, and I stayed on bed rest. I forgot that part of my story. And as I was sitting there, it just kind of came back. But what I do remember is when I got ready to give birth to her. Her name is Shanrika. And I was in labor for 18 hours. I lived 30 minutes away from the hospital. My mom brought me to the hospital 3 times before they would actually take me in and I would give birth. The 3rd time that I went back to the hospital in pain, my stomach was completely flat. And they said, well, where's the baby? And we was like, we don't know. I, too, was supposed to see the birth of my beautiful daughter. They told me they was going to give me an epidural. But when they did, and I found this out later, instead of it going to the lower extremities of my body, it went to my brain. No one knew what had happened to me. I didn't even know. But when I woke up, I said, well, what happened? I thought I was supposed to see my baby being born. And they said, well, we had some problems and some complications, and you had a seizure. And my mom just screamed because they never knew what had happened to me in that back room. In addition to that, when I went to see my GYN, he said, why did they cut you like this? Because I had to have an emergency C-section. And I said, well, I don't know. He said, they cut you like a pig. Every time I think about that, it hurts me to my core. Because it just makes it seem as if I was no more than an animal. I'm sorry. This was not supposed to happen. This is the core and the heart of the issue. Because here it is, some 40 years later, and Louisiana is leading the country in maternal mortality. And so it put me on a path that, again, I had suppressed those feelings, those emotions for years. Never talked about it. never talked about that experience, never talked about what happened, never talked about what happened afterwards. Was just so grateful to have my beautiful daughter. And consequently, I had a handsome son. And just never thought about it. But in 2020, by the way, I became an accountant, did auditing work. So I can tell you right now, my whole math skills has done a whole lot for me in the legislature. Helped me to really read the budget, Congressman. But my colleague, or my frat brother, lost his sister, who was only 33 years old and was 6 months pregnant and was doing fine. Somehow they did not catch that she really was suffering from high blood pressure. Rushed in to the hospital and died suddenly, unexpectedly. What seemed to be a great pregnancy going along, moving very well, turned very tragic. It took a very long time for that family to even come around to even talk to anyone about what was happening. That was in 2020, during COVID. So in 2021, I attempted to carry on a bill that Congressman Carter started to create the Office of Women Health. Initially, you guys know how this process goes. The bill started in health and welfare, flew out of health and welfare, didn't have any issues. But we got to the finance committee, and with strong opposition from many of my male colleagues, very racially toned as it related to, well, why is it just specifically, and we was like, it's not specifically for Black women, it's just dealing with the Office of Women Health and giving attention to the issues that women face that are definitely very unique. But just, we talked about her story. I shall never forget that day. I had to just sit there and kind of zone out for a moment to keep from just not jumping across the table. I'm telling you, it was tough. Because I was like, is he talking to me? Very disrespectful to one of the witnesses who came and talked about, she just shared various stories over and over about the encounters that women face and the lack of respect that she received there. And I'm thinking to myself, and I'm one of the male colleagues, one of my colleagues, African-American colleagues, I guess my face must begin to show what was about to happen. And he said, let's just take a recess really quickly. Senator Tarver, I shall never forget that. He called me, he said, baby, come here. He said, look, let me tell you, it's more than one way to skin a cat. Let me work with you, and let me work with the chairman so that we can get this bill through, because this is very important. And what you're talking about is so true. He said, but the way you're going about it right now, you're not going to have much success, but we're going to get this through, okay? So unfortunately, that year, we did not get the bill through. We had to end up turning it into a study resolution. And while we know that this information exists, and while we know that the numbers are high, when you have the data and you can come back and you can show that information, oftentimes it really helps you to get your bills through the process. And that's what we were able to do. So in 2022, we actually created the Office of Women Health in the state of Louisiana. I'm excited about that work, and what I will say to you is, unfortunately, we have less than 10 states that actually have an Office of Women Health created in its health or human Resource Division. And I am saying that I believe all 50 states and our territories need to have an office created with the intention of focusing on women's health. And not only that, because I have asked my good friend, Congressman Carter, and since you are here, Congressman Scott, I'm going to ask you guys to make sure that there's a line item appropriation to that office because we are struggling. The state is funding it now, and I can tell you that the resistance is still there as it relates to that office, but we are still pushing forward. And as a result of that information, this is what we were able to gather. Although we already knew that the numbers were high, but when you have the data, again, it gives you the ammunition that you need. In 2020, 90% of the pregnancy deaths were preventable. 93%. That's almost criminal. It is criminal. And in 2017, 2019, and they really told me not to really use this data, but 80% of the deaths were preventable. So it just shows us that we really have work to do, but when we put the intentionality to focus on those issues, we can begin to turn those numbers around. And so our office is still new, but I'm telling you, I'm looking forward in the next 3 years where you will see the data that actually prove how creating that office has begun to turn that around. And Louisiana will no longer be leading the nation in the highest maternal mortality rates in the country. In addition to that, in 2023, I also increased the pay rate of midwives. I am a product of a midwife back many, many years ago. But as you can see, I turned out very well. And then, of course, doulas. This year, I attempted to increase the pay rate of the doulas, and we were unsuccessful, but we're going to come back to do that once again. And to me, the heart of the issue is having the information to begin to put forth that information to turn this trajectory around. I heard someone a few minutes ago say together. That's right. That's right. You sure did say it last night, but it is together, because this is just not a black issue. It is a human issue, and together we can turn it around and we can change it. Thank you so very much.
Thank you so much to Raven White and to Senator Barrow for sharing your stories. There is a scripture that says we overcome by the words of our testimony. And I think a lot of times people count on us keeping our mouths shut and not talking about the things that are happening to us so that folks can act like they're not happening because we're not talking about it. But I am grateful for these women and so many others who have shared their stories. Next, we're going to move into the state of... Oh, okay, I'm sorry. Okay, never mind. Okay, I'm sorry. I'm trying to follow instructions here, but the instructions keep changing. We're going to... We rolling with it. We rolling with it. So from the Georgia House of Representatives, we have Representative Park Cannon.
All right. Pretty emotional this morning. Hello, I'm a doula. And I'm a lawmaker. I call myself a do-law. And I'm kind of looking for more of us. I feel like many of us have stories of doulas with us, and so we carry the doula story, but I want us to run for office because we then understand in real time what we're actually talking about. So I just want to share with you, and thank you for this invitation to discuss the heart of the matter. I truly feel as though I spend my time working on making sure that my clients' hearts are okay for the year postpartum. We have a new concern in Georgia where we have realized that 89% of our postpartum deaths within the year have to do with heart issues, and they were preventable. And so that 93% number from Louisiana and the 89% in Georgia is really intense to watch in real time. I work at a hospital. Wellstar Hospital is the first hospital system in Georgia to have a doula program where they have us on as staff. You can find out more about that program at tinyurl.com/Wellstar Doula Program. As an openly queer person in the state legislature, I have also taken up the important task of helping legislators understand where we're headed when we talk about birthing families. There is more inclusive language that we can use, and I hope that everyone will take an opportunity to look at ACOG's statement on family making that is not so gendered. This past year, I was able to chair a committee at the state capitol called the Georgia Maternal Mortality Committee, in which we reviewed the preventable deaths and we reviewed the documents from our review commission, which we have mandated to be no more than 3 years behind on their data. And you can find that presentation online at bit.ly/GA maternal mortality. We started doing other smaller things around the Capitol, wearing purple armbands like one I have on today that says eradicate maternal mortality. We started putting onesies and bibs on members' desks every day, certain members, and trying to get them to speak with birthing families. And they would get so excited when they would see the cute onesie or the cute bib. But then they might not vote the right way in committee, or they might not show up. I had a member ask me when we were discussing reasonable accommodations for pregnant people, ask, well, do they get a reasonable accommodation every pregnancy? And it's so important to really help people understand, that pregnancies are different every time, and they're attended to by different people. Unfortunately, we have a very closed system on who is allowed to be in that birthing room, and our goal is to open that up and make it more of an inclusive birth team to include midwifery. Of course, in Georgia, midwifery is still illegal. There are a number of different midwives who have served their communities and have been completely pushed out of the practice. Yes. And so we have now seen there be a rise in nurse midwifery and professional midwifery, to which, of course, you have to go to school, pay about $40,000 for books, or you have to go through a professional course. And so those midwives find themselves sometimes willing and able to find an OB who will basically precept them or who will have them in their OR at certain times. But it's still very difficult even for those midwives to be a part of the practice. And so we as doulas are hopeful that as midwifery comes back to the state of Georgia and is understood to be a safe solution, we actually saw our midwifery and at-home birth rate go up during the pandemic. It was a national average of 19%. We went up 24%. And so we do know that people are choosing to make these decisions to have their babies at home because it does feel more safe. We started hosting Community Midwife Day, bringing them and giving them resolutions at the state capitol. Please find those community midwives and revere them. We started talking about doula reimbursement. I did put in the legislation. We're still looking for some legislative sponsors for that who have an appetite for doing some of the kind of scope of practice work concerns that maybe some people may have. But ultimately, we do know that together we have the right solutions. And I'm just so proud to be here with you today. I hope that there is someone in this audience who is sharing their story and who wants to run for office. I did bring you a copy of my book on talking about that, and I'm happy to give it away for free to someone who's sharing their story and who soon will be on this other side of the podium. Thank you for having me today.
Thank you so much, Representative Cannon, for the information and the insightful comments that you've made. And we're going to probably have some folks to take you up on becoming a sister doula. as well. All right, so now we are running a little bit behind, but we're moving into the state of Black maternal health. And so for this portion, we just want to make sure that our panelists are working really hard to stay on track. So if you kind of see me doing this, okay, that means kind of wrap it up if you can, so that we can get through all of our speakers and get all of the information that we have for you. First, we're going to have Melissa Hurd, who is the director of Region 3, which includes Maryland, Delaware, Virginia, Delaware, Maryland, West Virginia, Pennsylvania, and D.C. from the U.S. Department of Health and Human Services, followed by Stacey Brayboy, who is the Senior Vice President of Public Policy and Government Affairs of the March of Dimes. Welcome.
Good morning. Preference, my colleague, Reverend Dr. Q English, who is also with HHS, has to catch a flight.
Okay.
So I'm going to, if we could switch.
Can do that.
And she can go ahead first.
We can do that. Thank you so much.
I appreciate
Reverend Dr. Q English is the director of Center for Faith-Based and Neighborhood Partnership in the U.S. Department of Health and Human Services. Dr. English, we'll get these out. Yeah.
Apologies for that. My time table was off, but thank you. And thank you, Melissa. So great for sharing this space with you. Wanted to honor Senator Louise Lucas from District 18, Speaker Don Scott, Virginia House of Delegates, and the Black Legislative Leaders Network, all the entire. Thank you so much for convening this. And I know you've convened this because of the urgent need to meet the needs of Black women, parents, and families seeking equitable, safe, and quality maternal health care. For far too many American mothers, complications related to pregnancy, childbirth, and postpartum can lead to devastating health outcomes, including hundreds of deaths each year. And we know this month we are acknowledging Pregnancy and Infant Loss Awareness Month, and it's essential as policy and program creators that we listen to and remember the stories of these women and men sharing their stories of pain, loss, and hope. I know for me personally, my daughter ended up in ICU. Both times were preventable. She had preeclampsia, and instead of treating, they sent her home with the Tylenol. And I'll leave that at that. So I am Reverend Dr. Q English. I'm honored to serve as the director of the Center for Faith-Based and Neighborhood Partnerships in Washington, D.C., and a proud appointee of the administration. I'm going to talk a little bit about the role of Health and Human Services in improving maternal outcomes for Black mothers. The Biden-Harris administration has worked with great intent to address this maternal health crisis with urgency it demands. I first want to announce that on October 9th, the Health Resources and Services Administration, HRSA, an agency of the U.S. Department of Health and Human Services, announced nearly $19 million in awards to 15 states to identify and implement innovative strategies to address the maternal health crisis. This summer, the Biden-Harris administration released a fact sheet as a progress report on the White House blueprint for addressing the maternal health crisis. Our activities were featured prominently throughout the fact sheet and included the first ever baseline federal health and safety requirements for maternal emergency and obstetric services in hospitals, including baseline standards for the organization, staffing, and delivery of care within obstetrical units, emergency services readiness, transfer protocols for obstetrical patients, and annual staff training on evidence-based maternal health practices and cultural competencies, among other topics. We also saw the release of our national strategy on maternal mental health that calls for a seamless integration of perinatal mental health and substance use care across medical community and social systems that increase equity and access, improve federal coordination, and elevates culturally relevant supports and trauma-informed approaches. We also had the first ever designation for birthing-friendly hospitals by the Centers for Medicaid and Medicare Services to describe high-quality maternity care. To earn that designation, hospitals and health systems report to CMS to measure their participation in a statewide or national perinatal quality improvement collaborative program and the implementation of evidence-based quality interventions in hospital settings to improve maternal health. We also saw an extension of postpartum Medicaid coverage for 2 to 12 months. We have 47 states have implemented, and the other 3 are working on it. We also have the launch of the National Maternal Mental Health Hotline, which has connected nearly 38,000 individuals to free, confidential, 24/7 support. It's a confidential, toll-free hotline for expecting and new mothers experiencing mental health challenges, 1-833 TLC Mama. Isn't that a great ring to that? TLC Mama. HHS also launched the Transforming Mental Health Model to improve maternal health care for people enrolled in Medicaid and Children's Health Insurance Program. The CDC has expanded the reach of her Hear Her campaign to raise awareness about urgent maternal warning signs to critical new populations. And then there was the HEROES program, Health Care Rewards to Achieve Improved Outcomes, aims to validate a radically different approach to creating preventative care incentive in the health market. It is an approach that involves offering direct payments to individual health accelerators, such as nonprofits that can successfully implement preventative care campaigns to improve the rates for specific health harms in an entire geographic population, such as severe complications during pregnancy or birth. And the administration, and the last piece I want to highlight is that the administration also highlighted the success of the Moms Tour. The Moms Tour is Maternal Outcomes Matter, and that is something that was spearheaded under the leadership of my office. It's much more than a community baby shower. We're going to states that have high maternal morbidity, mortality rate, and connecting pregnant and postpartum women real-time on-site with services and resources that they need. So if we're saying that suicide is the leading cause of death for women postpartum, 6 to 12 months, then we need to connect them to mental health services. If CDC is saying that doula and midwifery services, those that have that type of support system, fare better than those that do not, then we need to connect them to doulas and midwives. So I launched that in 2023. We did a pilot of about 11 cities. We touched about over 5,000 women and families, connected over 1,700 to mental health care services, over 800 to doula or midwifery service, over 200, over 500 to healthcare coverage. And we were able to expand the perinatal workforce with culturally competent doulas by over 200. And so that was in 2023 alone. And in 2024, we are targeting 25 cities. I have 5 cities remaining. It's been an incredible journey. We've already touched over 12,000 pregnant women, families, and dads, because it's not I'm pregnant, it's we're pregnant. So they too have their postpartum depression. So it's important that we include dads in this conversation. And to date, we are now over 400 culturally competent certified doulas and doulos, because the men joined the numbers as well. So we're excited about that. And then the next piece I want to tackle with you is talking about how can we partner with state legislators. Number one, I would love to partner with you on the Moms Tour. And for me, it was really important because even through those connections, we said we have a panel discussion to teach our pregnant women how to advocate for themselves in healthcare settings. And we say to them, you know, having a safe pregnancy, a safe delivery, and appropriate postpartum care is a right and not a privilege. And so if you keep going to your doctor over and over again, telling them the same thing, and they keep sending you home, I give them permission to fire their doctor. So I'm very serious about this movement, and we have several other movements that we're doing. So how can we connect? Number one, on the Moms Tour. Number two, I gave a guide that literally teaches community leaders and faith leaders how what are the things they can do practically? I would love for us to partner in getting that word out. And there are still states that have not expanded postpartum coverage, but we know they're coming along. I also would recommend meet with members of your state and highlight the stories of your community when advocating for policy change. And then support doula, culturally competent doula certification and access to training. And champion healthcare providers in becoming birthing-friendly hospitals. And yes, mandate the training for these hospitals who need it in cultural competency. In addition to that, and as I'm closing, encourage Medicaid coverage of community health workers who can act as liaisons and bridge to prenatal and perinatal care. As an example, New York State provides Medicaid reimbursement for community health workers services to pregnant and postpartum women, covering a typical range of services that include care coordination, system navigation, health coaching, patient advocacy, clinical support, and community outreach. My next recommendation is that when you receive funds from federal, we recommend that you look at the grassroots, community, culturally competent organizations that are really doing the work on the ground and assure that they get funding. A way to do this, I would also recommend, as we can do this in partnership, is hold these intentional listening and learning sessions with those that are doing the work on the ground. And please, in every conversation, and which you had today, include the voices of the lived experience. And last thing is, we need to work to improve maternal mental health outcomes. So we need more investment in that. If we're saying that is the leading cause of death, along with substance use disorder, there needs to be greater investments in those pockets. So greater investments in training, greater investments in providing additional resources for the organizations that are doing the work, etc. So that is where I'm going to end. I know I'm at time, but please do follow us at partnerships at HSS Partnerships, and you can definitely reach out to me personally at QUE.English@hhs.gov. That's QUE.English@hhs.gov. And I'm looking forward to continuing this journey until justice has cried her last tear. God bless you.
Thank you, Dr. English, so much for such insightful information. You've given us a lot to think about, and one of the things that I really like is that women don't get pregnant by themselves. Daddies are a part of that whole process, right? So, all right, so now as we move forward, and we wish you safe travels back to your next destination. Now as we move forward, we are really crunching for time here. Dr. Hurd or Melissa Hurd, Director of Region 3? Yep, all right. And see, Dr. English didn't look at me for the wrapping up. She just kept going. I noticed you didn't look up. You just kept going. It's all good. But just be mindful.
Right. Good morning again, everyone. Thank you so much for the invitation to be here. I see the speaker is in his absence, and to Senator Lucas and to this esteemed delegation. I am so happy to be a part of this conversation. My colleague, Reverend Dr. Q English, outlined a lot of what HHS as a department is doing to make sure that we are moving the needle in the space of maternal health. We can talk about all the statistics. We know that Black and brown women are dying at a rate that is 3, 4, sometimes 5 times higher than their white counterparts. We know that people feel as though they are not being heard, and we have implicit bias training and all of those things. What I really want to get to today is working on the solutions and how we can help make sure that we're bridging the gaps. When I heard Raven's story, I was enraged, as we should be. We should not have this in the richest country in the world. We should not. But it's still happening. And so what I've been doing here in Region 3, which covers the states of Delaware, Maryland, Pennsylvania, Virginia, West Virginia, and of course, the District of Columbia, what I've been doing in Region 3 is holding maternal health convenings. And it's not for the individuals who are giving birth. It's not for the families in terms of we're pregnant. It's for those intermediaries. the people who are standing in the gap, the people who should be advocating for our mothers, fathers, and even little ones so that they have a chance to grow up with their mothers. These are difficult times. We understand that. But at those convenings, we are listening to doulas. We're listening to doulos. We're listening to dads. We're listening to providers. We're listening to payers. And we're saying to them, where can we come to an agreement about getting information and resources to the people who need it most? If you are talking to someone who already has hypertension or diabetes, ask them how they're managing that condition before they get pregnant, during pregnancy, and after pregnancy. A lot of times people are saying, I'm pregnant, this is an exciting time, once I give birth, I'm fine. They don't know, as Raven just pointed out, what's happening with their bodies on the other side. That's why we push for the 12 months postpartum Medicaid coverage, and as Dr. English said, 47 states have already implemented that, and we're working on the others. The other thing is we are working with our federal agencies, especially the Health Resources and Services Administration, HRSA, to put more funding into the Maternal, Infant, and Early Childhood Home Visiting Program, or MCV. We wouldn't be government without all these acronyms, right? And so the MCV program, it was just announced, they received over $400 million from HRSA, from the federal government, to do and implement these home visiting programs. To bring that down to you, Virginia Department of Health was a $10 million recipient of those funds. So let's find out how the Virginia Department of Health is utilizing the MCV funds, how they're utilizing all of these other funds from the federal government. Are they working with the local connected organizations the way that Dr. Q mentioned? We also talked about the birther-friendly hospital designation that CMS, the Centers for Medicare and Medicaid, has put out. Of that designation, 41 facilities in the state of Virginia are birther-friendly hospital designations. How many people knew that? If you knew it, do you know where they are? And what's the litmus test for them having that birther-friendly hospital designation? And how are we holding them accountable to making sure that they are implementing what CMS has asked them to do and reducing maternal mortality and infant mortality? These are some of the things that we need to make sure that we're doing on a daily basis. Finally, with respect to time, I would just say there's a verse that says, where there is no vision, the people perish. We have a vision. We know what's possible, but the people are still perishing. And we can do something about it if we manage and pool our collective resources and don't stop. Keep pressing the envelope, keep pushing forward, and keep making sure that we are holding people accountable, even the federal government accountable in ways that can actually impact and uplift people's lives. We not only want good birthing outcomes, we want good maternal outcomes for both the mother, the family, and the communities we serve. I want to thank you again for your time. I will be here throughout the day. Dr. Q English gave you her information, but as the HHS Regional Director, I am also appointed by this administration. And so if you need any information, if you have any questions, please feel free to reach out to me. Before I take my seat, I want to give a big shout out to the crew that I've been working with here in Virginia, Senator Mamie Locke, of course, Bobby Scott, Congressman Bobby Scott as well, Gayleen Knoyton from Celebrate Healthcare, thank you so much, Anna James and Iris Lundy from Centera, and just a whole host of individuals that are a part of our community, part of our network, and working to make real change. Thank you so much.
So good morning. I'm excited to have the opportunity to be here with each and every one of you today. I want to first make sure that I say thank you to Speaker Scott, to Senator Locke, Senator Lucas, and Delegate Candy King, and all of the electives, Virginia electives that are here. I commend you and thank you all for bringing us together for our first annual Virginia Legislative Maternal Black Health Summit. I heard the speaker say on last night that this is the first, but it won't be the last. And so hopefully it will not be the last. And that today you will hear something from the stories that our advocates, stories that our families share with you. My job is to share with you some information regarding policy discussions and set the framework for what you will hear today as a member representing March of Dimes and our perspective on the state of maternal health. We know that healthy moms and babies are entwined and that you cannot separate certain conditions that affect the mom will also affect the baby. My hope is that the information that I share with you will help to inform and inspire a path forward for all of us to be able to work in our communities, you as our legislative representatives, as our congressional members who are here with us as well, and members from across 10 different states that I've had the opportunity to meet. What we're attempting to do here is important, and we're going to need to partner. And we're going to be able to take back the stories that you hear here, the examples of legislation that is taking place across the country at the federal and at the state and local levels, and see how we're able to lock arms. And let's make sure together we're able to do something. Together, do something. I am trying to advance this. I'm pointing here. Just really quickly, I'll go through the slide presentation. I'm with March of Dimes. March of Dimes is a nonprofit that has been around for 85 years, started by President Franklin D. Roosevelt. Initially, our focus was on eradicating polio. We were successful at being able to do that. We have turned our attention over the last years, focusing on the health of moms and babies, looking at it from conception through the pregnancy journey and after the pregnancy journey postpartum. March of Dimes leads the fight for healthy moms and babies, and we believe in a world where every mom and every baby, regardless of your wealth, regardless of your race, regardless of your education, or where you live, should not have an impact on you being able to have a successful pregnancy journey. There's a serious maternal infant health crisis that requires us addressing health equity and the fight for healthy moms and babies. What you see is a picture of the Johnson family, Kira Johnson, and you see a picture of the Lasmer family. Let me tell you a little bit about the two of these stories. The Lasmer family on the right, their story, fortunately, had a happy ending. Baby Gabrielle was born at 28 weeks and stayed in the NICU for over 2 months. This experience is not an experience that any family plans, but Gabrielle was able to come home and thriving. Kira Johnson, for Kira, for moms, whose family that is pictured on the left. Kira was healthy, 39-year-old, smart, intelligent, educated, went into the hospital to have her second baby. She and her husband were told by the doctors for hours that there was nothing wrong, when they would continue to tell them that there was something wrong, and their story was ignored. In the hospital, she and her husband, and many of you probably have heard this story from Charles Johnson, and so when I think about it, it gets me a little bit teary. Kira's death was a shocking outcome, but it was an outcome that was preventable because they tried to notify the doctors, grab attention, but no one would listen. This was preventable yet ignored cause of Kira's death is one of three reasons and 3 times that we can look at the fact that 3 times as many Black women than white women die from child-related issues. Let me share some statistics. You've heard them. You will hear them throughout the remainder of this summit. The U.S. is facing a serious maternal infant health crisis, and that's why you all have convened us here at this summit today to talk about and look at the causes and look at solutions for how we address it. 2 women will die from pregnancy-related causes today and every day. 2 women. That means 2 babies die every hour in the U.S., and that means that twice as number of pregnancy-related deaths have doubled in over 30 years. We've got more than 2 million women who have no access to obstetric or providers, birth centers, hospitals, or hospitals that are even offering OBGYN services or care. We've got over 5.6 million women who have and live in areas that have no access to maternity care. And it's not just in states or cities that you think, suburban areas or rural areas. It's happening across the country. The U.S. remains, as you've heard earlier, you've heard it last night, and of course, I could not leave without saying the U.S. remains among one of the most dangerous developed countries in the world to give birth to a child. We only hear the stories about making it to the first birthday. We never hear the stories about what happens when mothers go home, mothers and fathers go home. What happens in the hospital? Access to maternity care. March of Dimes releases this report every 2 years where we do a lot of extensive research, advocacy, and education. 35% of the U.S. counties are designated as maternity care deserts. Almost 60% of those maternity care desert counties are classified as rural. And remember, I just said, don't take away the fact that 40% of urban areas are also classified as maternity care deserts. States with the highest percentage of maternity care deserts: North Dakota, South Dakota, Oklahoma, Missouri, Nebraska, and Arkansas. Each month, March of Dimes releases a report card, and it's where we score the states and what you're doing in your states collectively to address the maternal health crisis. I want to draw your attention to the graph that's here, outcomes in maternity care deserts, how it impacts, looking at the percentages for higher maternity rate deserts compared to those that have full access. I will definitely be around, but for sake of time, I'll move forward, but I'm here to answer any questions. And if you have questions specifically about your state, I will also be around, but I will move forward. Social drivers of health. Maternal vulnerability index for social economic determinants of health by each county. And so I've met people from Georgia, I've met people since I've been here from Minnesota, Oklahoma, Louisiana, South Carolina. And what I'll ask you to do is just take a look at where your state is, look at the color, look at what your maternal vulnerability is. We look at the influence of race on maternal and child health outcomes. Preterm birth rates are higher for Black women and other women of color. Women of color are 50% more likely to have preterm births, and their children face 130% higher rate of infant death rate. As we shared earlier, Black women are 2 times and 3 times more likely to experience death from pregnancy complications compared to white women. Black women lose their lives more often regardless of your education, your health conditions, or your income. Highlighting Virginia, 9.7. I was told not to do this, but I want to do this. North Carolina, South Carolina, Georgia. For everybody I've had a chance, I met someone from Minnesota and from Michigan that's here, legislators who are doing things in their states. Thank you for what you're doing and continuing to work together, as Senator Lucas said, is how we're going to be able to address this national health crisis. Disparities in preterm birth. They're higher amongst Black women rather than other women, other races. Take a look at this. Next month will be National Prematurity Month, and we will release our annual report card. I'll give you information for you to be able to look and find your state and see where you stand with your grade in terms of what's happening collectively in the space. There's a higher chance of maternal death or preterm birth based on race and ethnicity. What I've given you here is just brief synopsis of, regardless of your education, obesity, your income, Black women experience higher pregnancy-related mortality rates. Women of color, 50% more likely to give birth to preterm, and their children can face higher death rates. In summary, let me share, there's a lot of work that is already starting to take place. I've had the opportunity to work with many of you here, and many of you are seated behind me and have joined us here today for this legislative summit. I want to thank you for your time. I want to ask each of you to listen to the stories, take the stories back, take the data that I have shared. There's more that I want to share, but being respectful of time, I move forward expeditiously. I encourage you to visit our website and learn more about maternity care deserts. And then I'm going to challenge you in National Prematurity Month, November, to wear purple, but also go and take a look at the March of Dimes annual release report card that grades your state. The maternal and infant health crisis is a complex one, and we all know it. And while there's not one solution that will improve the healthy outcomes for all moms and babies, together, you've heard Senator Lucas say it, you've heard Mrs. Hurd say it, you've heard Dr. English say it as well. Together is the only way that we're going to be able to bring about real change in all of our communities across the country. Thank you. When you leave today, I want to challenge you all to go back and do something.
Thank you, Stacy. Our next presenter is going to be Dr. Lasha Clark. Did I say that right? Did I get that right? Lachey, thank you. Names are important. We're going to get it right. Dr. Lachey Clark, the Assistant Director, Center for Maternal Health Equity at Morehouse School of Medicine. Dr. Clark.
Thank you. Good morning, everyone.
Good morning.
Thank you so much to everyone here for this opportunity to speak to you and to share this important information, much of which you've heard from our speakers throughout this morning. So I'm Dr. Lachey Clark. I'm Assistant Director at Morehouse School of Medicine's Center for Maternal Health Equity, and I'm also Director of our research studies. And really what drives my work there, and really all of our work there, is a profound sense of urgency to advance maternal health equity for Black women and birthing people across Georgia, where, as you've heard, Black women are 3 to 5 times more likely to die from pregnancy-related causes compared to white women, depending on where in the state that they live. And so we know that in rural Georgia, in particular, that rate is closer to that 5 times more likely, and that's because of exactly what we just heard from Stacey Brayboy about the maternity care deserts that exist, particularly in rural Georgia, but also in urban areas in Atlanta, for example, as well. So at the Center for Maternal Health Equity, our mission is to pursue equity in maternal health by eliminating morbidity and mortality locally, nationally, and globally. Over the past 3 years, we've been entrusted with over $20 million in funding to drive impactful solutions, and the major way we do that is through listening. We make space for Black women, Black families to tell us what they need because they know best, and then we leverage our resources to act on what we hear. So in that way, community engagement isn't just a part or a component of our work, it's really the foundation of the work that we do. We're firm believers that Black women are not merely patients or subjects to be studied. Rather, they or we are producers of essential knowledge. Black women's lived experiences reflect deep insights into the barriers we face and the solutions we know will work. But for too long, many policymakers, academicians, etc., have ignored this expertise and instead focusing efforts on policing Black bodies, whether through restrictive reproductive laws, underfunded maternal care, or criminalization related to behavioral health issues, like we heard earlier around the substance use disorder crisis that's ongoing. So policymakers and researchers alike must engage with Black women and recognize that listening to Black women cannot be optional. It must be the standard for designing policy that truly meets our needs. So with that said, I want to share just a couple of our center's ongoing key initiatives, talk through how we're listening closely to Black experiences and responding in a way that centers reproductive justice, research justice, and data justice, and share how our community engaged work has already influenced policy and will continue to do so in the future. So one of our most impactful projects so far is our maternal near miss study, which centers the narratives of women who nearly died but survived a treacherous pregnancy or postpartum experience. And some of the stories we heard are exactly like the ones that we've collected through this maternal near miss study. We've gathered stories from nearly 100 women, and one of the ways in which we were able to use those stories, those voices, is as testimony to support the passage of Senate Bill 338, which passed during the 2022 session, and as we've heard, allowed for postpartum Medicaid extension 1 year after birth. Those narratives really help to highlight the need for continuous care in a critical period beyond birth. However, we know we need to go beyond Medicaid extension to address these systemic and pervasive issues that affect health throughout pregnancy and beyond. Another one of our active studies is CORAL, which stands for the Center on Advancing Reproductive Justice and Behavioral Health Among Black Pregnant and Postpartum Women and Birthing People. This is a federally funded and NIH-funded collaboration with Emory and a host of community partners that we work with that are based in Georgia and around the nation, including Black Mamas Matter Alliance, Georgia Department of Public Health, March of Dimes, and so on. And through this study, we're really focusing on maternal behavioral health and looking at the intersection of the maternal health crisis and the behavioral and mental health crises, including substance abuse, for which we know Black bodies are disproportionately criminalized and underserved, and the correlated intimate partner violence that sometimes goes along with substance use, behavioral health issues, mental health issues for our birthing people. So we saw a much needed opportunity to pool our resources across academic institutions and across our academic and community partnerships to really do something about this issue. And one of CORAL's flagship research projects is called OVAL, which is examining actions that state legislatures have taken to pass laws governing drug use, some of which are punitive and seek to deter prenatal drug use through criminal sanctions, and others of which are more supportive and seek to expand substance use disorder treatment for pregnant women. And our goal there, as time goes on, CORAL is a relatively new project, is to equip policymakers with evidence-based information that we can use to help Black pregnant and postpartum women and birthing people who use drugs to survive the collision of the Black maternal mortality and overdose epidemics. Finally, I have to say a quick word about our fertility equity study, which addresses the often overlooked issue of infertility among Black women and reveals barriers to care and a lack of culturally responsive fertility treatments. In our very reasonable focus on maternal health outcomes and Black maternal health outcomes, we sometimes aren't considering the rights and experiences of those who wish to become pregnant but face difficulties in doing so. And this is the same population of folks who, once they do become pregnant, will be facing the same systemic barriers that the women that we've been talking about today and hearing from today are experiencing. And so we're using findings from our fertility equity study as a basis for the Georgia Fertility Justice Now campaign. You heard it here first. You'll hear more about it as time goes on, I'm certain, which is dedicated to increasing access to fertility care in our state for all individuals, regardless of race, ethnicity, ability, economic status, sexuality, and gender. So we're leveraging our research, which centers the voices and stories of Black folks, to advocate for a Georgia insurance mandate that would require coverage of fertility care, including in vitro fertilization. Many of us understand from either personal experience or otherwise how cost prohibitive infertility services, fertility care can be. And so we really want to do what we can to eliminate that barrier and work together with our policymakers to bring that to light for our population. And so we'll be urging our policymakers to support this insurance mandate and sponsor the bill that we're drafting, because this is not just an issue of healthcare access, but one of reproductive justice and equity and support of, like others have mentioned, respectful, patient-centered care throughout the reproductive journey and not just during pregnancy. And our center additionally has teamed up with Sister Song, Women of Color Reproductive Justice Collective, which is an organization based in Atlanta with national and global reach, to create the first ever Black Infertility Awareness Week. National Infertility Awareness Week has been a thing since around 1990. We created the first Black Infertility Awareness Week to really speak to the disparities in infertility that affect the racial disparities in infertility that affect Black women that are very similar to the racial disparities in maternal health outcomes and infant health outcomes as well. That happened for the first time in our nation in July and will be happening again next July. So please stay tuned for information about that, or please feel free to reach out. And so those are just a few of our projects, but they demonstrate that achieving maternal health equity requires strategic policy interventions informed by Black women's voices and experiences. So thank you for your time and your leadership in advancing maternal health equity across the nation. And please don't hesitate to reach out to our center. Please visit our website at centerformaternalhealthequity.org. Please feel free to reach us there and through my email address, which was up on the screen. I'd love to hear from any and all of you so we can work together in partnership to move forward toward a better future for our people. Thank you.
Thank you so much, Dr. Clark, for your insights and for that information, and for all of our panelists who spoke on the state of maternal health. These are stories that we're hearing over and over and over again, and we're gathered here today, obviously, to make sure that we are able to minimize the story by improving the state of health. We will move on to policy and community partnership. We've got two speakers there. We are almost catching up on time. And so I'm going to ask that Roseanne Maria Purim. Did I get close? Very close? Okay, I'm hooked on phonics. All right.
It's Maria Purim, but I also couldn't spell it until the third grade, so, you know, it's a journey.
Very good. All right, so Roseanne Maria Purim, JDMA, who is the Senior Policy Counsel at State Innovation Exchange, followed by Dr. Leah Alexander, from the Department of Public Health, the Meharry Medical Center.
Thank you so much. And it's such an honor to be here and such gratitude for the invitation to come speak. So first off, State Innovation Exchange, or SIX, is a nationwide strategy center and resource center for state lawmakers. We were founded 10 years ago because we know that state lawmakers have to be policy experts on hundreds of issues, and specifically, I am a member of our reproductive rights team. These are my incredible colleagues, and we're just honored to do this work in partnership with state lawmakers every day all over the country. SIX is fully remote. I'm based in DC, but we work in all 50 states, and our team is all over the country. So I want to name that we work on a variety of issues. Although I'm on the reproductive rights team, we also work on agriculture, democracy, economic justice. We're really pushing for progressive change all over the country, and we specifically, in these highlighted states, have staff who are state directors there. My favorite pictures. These are some of our incredible lawmakers who are members of our Reproductive Freedom Leadership Council. We bring state lawmakers' voices into the national arenas as well. We also bring them abroad, so you'll see there that we have a delegation that went to Mexico 2 years ago to talk about abortion access in Mexico and how they expanded there at the same time that the United States was experiencing restrictions. We also have lawmakers at the White House, at the U.S. Supreme Court last year, working on several cases. So we know it has never been clearer that state legislators are among the most important battlegrounds for progressive change. And we also know that you all have 800 hats. And so we know you have to be a speechwriter, a truth teller, a policy expert, and that you're sometimes doing it alone or with very limited resources. So 6 was designed to be supportive and be responsive to the needs of state legislators. This is just an example of some of the elevation we do with state lawmakers' work. I want to name the No Democracy Without Black Women work that has been ongoing from 6. We really know the intersection between reproductive freedom and democracy. And so we're constantly looking at your work and saying we need to show the national level how powerful states are. So what does that look like? Here in this photo is an example of state lawmakers at a White House convening we did last summer on the anniversary of the Dobbs decision. We wanted to talk about how state lawmakers were fighting for reproductive freedom in the states, even though the constitutional right to abortion care had been removed. We regularly provide informational webinars and newsletters, so being a member of our network gets you access to those resources. And then we also connect lawmakers to research and clinical experts in the field. I was just at our Midwest research convening in Ohio, where I'm originally from. We work with lawmakers and researchers from Ohio to talk about maternal mortality rates in the state. And also we take folks internationally to places like Mexico, the Dominican Republic, and El Salvador. In those delegations, we talked about LGBTQ rights. We talked about improved access to doulas and midwives and other birth workers. So that's kind of the scope of a lot of those trainings. Lastly, on our website, we have all of our resources available for free for lawmakers, and I can also customize them to be necessary for your state, which I'm going to do a visual aid right now. This is our Black maternal health packet of sample legislation from states all over the country. Just to give you an example of what it includes, we've talked about a lot of the policies already, but how do we increase access to birth centers and have insurance coverage and reimbursement rates for birth center births that are comparable to those of hospitals so that birth workers in the community can get care and also be reimbursed appropriately? How do we support incarcerated pregnant and parenting people? How do we improve access to doulas and midwives? So these are sample bills passed by some of the lawmakers who are here from other seats, including Rep. Park Cannon. And it's constantly updated. It also has a QR code, so you can have the most recent version of these bills. It's constantly updated. I was doing it on Monday. So we really try to make sure that these resources are best tailored to the community birth workers, especially the Black-led community birth workers in the state. So they are samples that we can then adjust. So how do you get involved? The Reproductive Freedom Leadership Council. If you are a lawmaker, we would love you to be part of the RFLC. There is a QR code that you can get more information about what we do and how we can support you. We are so honored that so many folks here in Virginia are already RFLC members. We try to elevate your incredible work because we know that what is happening in Virginia is leading the way on reproductive health care across the country. And so we know that we need to elevate your powerful advocacy. And just a little bit examples every year. I don't know how that ended up there. Every week we celebrate Black Maternal Health Week, and Delegate Candy Minda King is one of our incredible spokespeople. And so we also lift up things on our blog and one-pagers. So obviously the word uplift has been said like 600 times by me, but it's just because we know how powerful your work is, and we're really here to be supportive. So much gratitude for your time. I am at a table right out front. I have copies of the legislation. I also have my business cards, so just really grateful to be here. Thank you so much.
Good morning. Do I have slides? I don't know if they got. Are they? Okay. Well, I'll go ahead and get started. So, good morning. My name is Leah Alexander. I am
I'm the chair of public health at Meharry Medical College in the School of Global Health. I'm thrilled to be here and just really appreciative of the invitation. In my professional life, I do public health education and research all day long. But in my personal life, like many of us here, I'm a sister, a mother, a daughter, I'm a wife, but I'm also a survivor. And I'm a picture of many of the women that I think we've been talking about here today. I've survived 2 poorly spaced geriatric pregnancies, and that's what they say when you have, babies in your late 30s or later. But I've also survived preeclampsia. I've survived the NICU for 90 days with the birth of my son. He was born at 28 weeks. And every time we were supposed to go home, he would have an apnea, so we'd have to start all over again. And it was probably one of the scariest times in my life. And before we left, although I know the nurses were trying to be helpful, they said, go introduce yourself to the fire department. So they send us home with this, new baby. But just in case you have an emergency, they know who you are. So we were totally afraid of, our son, probably for, the first few months of his life. But somewhere in there, and who knows how this happens, I know I'm a public health practitioner, but who knows how this happens, I got pregnant again. So I have, two wonderful children that I'm really thankful for. But I also stand before you as a woman who, in her younger life, had to make a decision to terminate a pregnancy. And it's something that I didn't take lightly. And it's something that, you think about a lot when you have to make those types of decisions. So as I think about my daughter in this country now, with what we're facing, not being able to make those types of decisions for herself, it is terrifying. So I find myself in a place where my personal life and passions are really informing my professional aspirations. I'll keep going. If I don't have slides, I don't need them, but I'm just going to check in to see. Not? Okay, so I'm also a proud Meharrian. So Meharry is a historically Black academic medical center in Nashville, Tennessee. We often celebrate folks being #Meharry made, and so that's what kind of happens once you come to Meharry. Love it, maybe wanting to leave it sometime, but you get through. So we talk about being Meharry made. While I'm not Meharry made, my mother received her PhD at Meharry in microbiology. So I really did grow up ripping and running in the hallways and sneaking around in the science labs when I was a child. So I often say that I am, in fact, Meharry made. So we're known and sort of celebrated for training Black physicians. The latest statistics that I heard is we're responsible for training probably 10% of Black physicians in this country. 30% of Black dentists in this country were trained at Meharry. But we also have 3 other schools. So we have a school of graduate studies, which is thought to probably be responsible for about 20% of African Americans who hold PhDs in the biomedical sciences. But we're changing the face of healthcare one student at a time. We have a new physician assistant program, so Black folks are very underrepresented in that field, and we intend to change that. We have a school of applied computational sciences, so we're training data sciences. And then our new school of global public health, where we're training public health leaders, policy experts, and global health scholars. So Meharry is one of 2 medical schools that actually was able to survive the Flexner report. And I don't know if people are familiar with the Flexner report, but it was a study that was done to sort of increase the rigor of medical education in our country. It's about 100 years old. Statistics suggest that if Some of the other medical schools that existed at that time had been able to make it past that report and still train people of color. We would probably have 25 to 30,000 more providers of color in our nation. And so a lot of the issues that we're talking about sort of stem from the fact that we don't have folks who are practicing medicine, making policy, public health leaders that look like the folks who are having the challenges. And so that's really what Meharry sort of, is committed to, and also fighting for health equity. So we've shared so many statistics, so I won't go through it. I do know Tennessee is probably, I think we get a D on the March of Dimes list, and we've probably been at a D for quite a long time. But there are things to celebrate, from the state of Tennessee. We have powerful state senators. Charlene Oliver is one that was just on campus talking with our students about really what has happened since Dobbs was overturned. So a lot of us probably aren't thinking about this, and we know that you are here and we know what you are doing, but it really makes a difference for, you to come to schools and talk with students. Charlene lit a match under our students, increasing the number of students who want to work in this particular space. So having those types of interactions and just learning more. So Charlene is fighting for abortion rights and reproductive justice. She talked to us about the complete abortion ban in the state of Tennessee and the fact that there are limited exceptions. She let us know that a lot of Tennesseans are actually women who are seeking abortions have to go out of state. So they're going to Illinois if they, are struggling with those issues. So there's a lot of work to be done everywhere, but I agree and am very excited about the opportunities to work together. The other thing that I would like to share about some of the things that's happening at Meharry that are worth celebrating is funding that we recently received from HRSA to establish a maternal health equity research center. And so in that center, we're going to focus sort of on three things: increasing research. So we are committed to community engaged research. So that means that the topics, what we're going to address, start with community. And we bring our expertise with community expertise to address issues that community are passionate about. We also will be establishing a maternal health equity track for our Master in Public Health program. So we're excited that we're going to be adding to sort of a cadre of experts that will be working in this space. And then we're going to work on advocacy. And so we do community engagement. We want folks in Tennessee to really understand this issue, to get passionate about it. But as I'm sitting here and thinking about, my time with our legislator, we really have to get community engaged around the political process. And so while we didn't talk about this at the beginning of our project, I do think that we need to do a little more advocacy and education with, folks in our community and get people interested in the political process. So I'm excited to be here. I'm just thankful for the opportunity and look forward to more conversation today. Thank you.
So I want to give a big thanks to all of our presenters. Let's give them all a hand. Between the stories, the information, the facts, the figures, and all of the work that is being done, I think we are moving the needle, however, not fast enough, but we are moving the needle towards better outcomes in maternal health. So what we're going to do is we're going to take 60 seconds, like I'm literally going to start the clock at 60 seconds. And we have our upcoming panel moderated by Delegate Marcia Price, on the topic of congressional testimony style facing, moderated by Delegate Marcia Price. I got instructions and stuff that y'all not supposed to know about. Her panel is gonna be Healing the System, Redesigning Systems to Promote Maternal Health Equity. So we're gonna take 60 seconds to get our panelists who are, hold on here, Kenda Sutton-L, Dr. Noel Kamiko Jeffries, Nicole Wardlow, Dr. Amber Price, and Shanice Gangadine, who are going to be our panelists for this discussion. 60 seconds. I'm Senator Angela Williams-Graves. Thank you so much for the opportunity to moderate this morning's session, and we'll see you in 1 minute. Nine, 8, 7, 6, 5, 4, 3, 2, 1. Clap once if you can hear me. All right. Thank you. Thank you. All right, so ladies and gentlemen, we are going into our panel with Delegate Marcia Price. Our topic is Healing the System, Redesigning Systems to Promote Maternal Health Equity. Delegate Price, take it away.
Okay, thank you. Good morning, good morning. I'm Delegate Cia Price from Newport News, Virginia, and I am excited about our upcoming conversation. As we know, technological and medical advances in healthcare are happening rapidly. We have witnessed groundbreaking treatments for sickle cell anemia, cancer, and other conditions, yet Black maternal health outcomes continue to be of grave concern. As you've heard this morning, but deserves being repeated, data from the Centers for Disease Control and Prevention show that Black women are 2 to 3 times more likely to suffer pregnancy-related deaths than white pregnant women. And the importance of our work together today is based on the fact that most maternal deaths are preventable. Our goal in this conversation is to talk about the changes needed to drive equity across our systems. We are joined by a diverse panel of experts who have committed their careers to healthcare. Their full biographies are in your summit package, but I want to share a little bit about our panelists before we begin. Kenda Sutton-L is the founder and executive director of Birth in Color, an organization committed to dismantling systemic barriers in maternal, reproductive, and infant health. Kenda's work emphasizes diversity and inclusion, specializing in training people of color to become doulas and conducting racial bias training for healthcare systems and professionals. And those of us who have been working in this topic are no stranger to Kenda's work. Dr. Nolene Jeffers has over 10 years of experience as a nurse midwife. In her research, Dr. Jeffers utilizes a reproductive justice lens to examine the structural and social determinants of Black maternal and perinatal health. She currently leads or collaborates on studies that examine the impact of midwives and birth center care on perinatal health, racism, and discrimination in midwifery education programs, and the integration of doulas into the state perinatal health systems. Nicole Wardlaw is a certified nurse midwife with over 16 years of experience in health education, full scope midwifery services, and clinical faculty advisory. Nicole is Virginia's Midwife of the Year and a leading, yes, Nicole, and a leading advocate for reproductive justice, and I would like to highlight is a graduate of the illustrious Spelman College. Dr. Amber Price joined the Centera team as president of the Centera Williamsburg Regional Medical Center in Williamsburg, Virginia in March 2022. Centera Williamsburg Regional Medical Center is a 145-bed acute care hospital that serves the Upper Peninsula region. And of course, we know that Centera Healthcare has been a leader in establishing Centera Midwifery Specialists in Hampton, Virginia. Shanice Gangadine has built her career as a registered nurse in managed care, focusing on supporting Medicaid. Within a decade at Anthem, Shanice has served in several roles, moving from case manager to program director, and she now serves as the director of foster care, where one of her goals is to improve the maternal health of young women in foster care or aging out of foster care and beyond, based on her lived experience in the foster care system and as a Black woman and mother. Y'all, so you can see why I am excited about this conversation. So my first question comes to each of the panelists. When we look at the inequitable outcomes for Black women, Indigenous women, and others, particularly the high maternal mortality rates, in 1 minute or less, what part of our systems should be prioritized for redesign? And Nicole, we'll start with you.
One, we need access. We need access to the people who are in the system, who understand the system, who listen to the clients, okay? I'm a midwife. I've been a midwife for 19 years. I left the hospital to go into the community because it was the women in the community who said we would rather stay at home and deliver our babies at home unassisted versus going into the hospital systems because they were afraid. And so now, we and the rest of our team and the people that we work with, Kenda and her doulas and other midwives, are taking care of these people. We started that practice so it would be a hospital-based practice for access. That's the biggest thing, is access and listening to these clients.
Yes, please.
Thank you. You know, from my personal experience, we need early, effective, preventative care, and we need education. We need to be able to educate Black mothers on what to expect throughout the whole entire journey of pregnancy and what to expect during a possible miscarriage or when something doesn't go right. From my personal experience, I've been pregnant 5 times. 2 of them resulted in childbirth. My first son was a healthy boy. We had a healthy pregnancy. I had a doctor who looked like me. I had a doctor who prayed for me, understood my faith, and connected with me. And my second time of trying to have a child, it ended up being I had a miscarriage. And my doctor, that same doctor, she held my hand. She was there for me because she understood what I was going through. My second time I had a miscarriage, I didn't have the same experience. It was different because I didn't have a doctor who looked like me. I went in and I was gracious. They found that it had no heartbeat. And she callously said, "It's already gone." And me and my husband, we looked and we said, "Well, what do you mean it's already gone?" "It's already gone." I said, "Okay, well, please, can I get a DNC? Can I get a dilation and curettage?" And she said, "Why? it's already gone. So she sent me home to miscarry on my own. I'm a registered nurse. I thought I knew what I was doing because I was like, oh, this is just like labor, right? I almost died at home. I was strong. I was doing like schoolwork for my master's degree, and I was miscarrying, and I didn't know that I was losing fluids, that I was just the danger that I was in. I ended up back at the hospital. They checked me out. They said, you actually did get through, but you lost so much fluid, your blood pressure is so low. That doctor sent me home with no care, delayed my dilatation and curettage request. Then I had another miscarriage, but this time I was back with my original doctor from my first child. She immediately got me to a DNC, held my hand, prayed with me, understood my faith, understood where I came from, educated me on breastfeeding and everything that was to say. So from my personal lived experience, I would say we need prevention, education, and sustainable systems that allow continuity of care and more doctors that look like us. Thank you.
Thank you. Good afternoon, everyone. So first, I would say we need more transparency. You know, we get up here and we talk about what's being done, what's this, and like all of the things, but a lot of people aren't being honest about what's actually happening on the surface when you're looking at the grassroots level. We have so many different legislation and things that have been done, but when we come to the legislators and we say, oh, this is what's happening, they're like, wait a second, we put this protocol in place for a reason. And so even when you look at the doula reimbursement model, it was like one of the best things ever, but now you have where hospitals are trying to control doulas, which is really going to affect the outcomes. And so when you look at it from that lens, it's like, okay, now they have these vendor forms that they want doulas to sign. The forms say doulas will not advocate, when that's our biggest asset. And that's why doulas don't work for the hospitals, because we actually work for the patient. And then when you look at the collaboration, the community collaboration with the healthcare system, we always appear as like, oh, this is going great because they'll sponsor something. But when you look at people like, and I know she might get upset that I'm going to say this, but Nicole Wardlaw, who actually helped to build the Centera midwife practice along with us. We pushed so many people. They had the community didn't want to go there. And we said, no, they actually are doing great. They got midwives and all of the things. And she had a community collaboration agreement with that hospital. And then all of a sudden, because she had her own home birth practice, which they already knew about when they hired her, they actually let her go when all of our patients were like, being seen. We had one particular client in particular that the client, I was her doula, and I actually drove from Richmond to Hampton because I'm looking at, she goes in, Nicole tells her to go in to check her blood pressure. She's like, oh, something's wrong. I just can't see what it is. Go in and get checked. So the patient went in to get checked, and then the patient's like, oh, they did a strip for 20 minutes, and they're sending me home. And I said, no. Don't go home. Wait a second. So I called Nicole and I said, hey, can you look at this? Because this doesn't seem right. And she's only been on the strip for 20 minutes. So she goes to the system and she looks and she's like, oh no, like she's having these details, like these things is going on. So she calls in and she actually goes into the practice. And we both actually end up at the hospital and we're like, no, she can't go home. And Nicole is like, no, she's not going home. We're going to deliver today. So I drive from Richmond to Hampton. And then upon getting there, we see all the things. And of course we work together because that's what Black women do. And so we ended up having a healthy baby, but had they not had the privilege of having me as a doula, me knowing Nicole and having her phone number, this patient would have actually went home and who knows what would have happened. And so we're looking at the data real time and like, okay, so what's actually happening? And so I think like as people come to talk about their stories and then hospital systems get up here, like let's actually really have transparent conversations so that our legislators can do what they actually need to do when it comes to implementing these policies.
Good morning. Thank you for hosting us here today. It's an incredibly important topic. I am a hospital president, but what you may not know is that I spent 10 years as a doula, a nurse's aide before that, and then became a certified nurse midwife and worked in rural communities around the world. I was actually trained in New Zealand with the Maori population and had a very unusual career trajectory. That puts me in a seat now as an executive lead for women's health in the largest healthcare system in the state of Virginia, knowing the stories of the women that I cared for 20 years, side by side. I was in their homes. I understand the lived experience of our patients, and I also understand the issues that the healthcare system faces in trying to provide the kind of care that gets us to our goal, which is zero harm to our patients. It is extremely complex. But what I can tell you is that one of the issues that we face is that we are extremely siloed. And so when you run a hospital, your thought process works along the lines of, we care for the woman when she comes in to have her baby or when she has a medical emergency. And that means that we might not know this patient at all. We've never seen her. She's with a private physician in the community. We get to know her the minute she lands in labor and delivery. That may be the very first time we know that she even exists. We have to connect, understand her medical needs, her emergency, and manage that, also trying to meet her cultural needs, her trauma needs, every other need that woman may have, all the baggage that comes with her history in a very short amount of time. She may only be with us for 48 to 72 hours for that entire experience. And what we've done is assume responsibility for that 72 hours. But where I see our opportunity is that we understand that this care is on a continuum, that this care does not just happen in those 72 hours. And so we need to get better about understanding how we connect with this woman from the minute she is even thinking about getting pregnant, throughout her pregnancy journey, the birth itself, and that entire vulnerable year after she has her baby and she is not in the hospital. In the end, all medical emergencies end up back in the hospital, regardless of what that emergency is. And so the recognition that we as a health system have an opportunity to be present and walk with these women for the 95% of the time they're not in our buildings and they're not anywhere, that is where we see we can have the greatest impact, and that includes the health plan side. Creating reimbursement for those things that are pivotally important to keep women healthy for that 2-year time span needs to be integrated in that continuum.
Good morning. Thank you for having me here. I am a midwife and a researcher at Johns Hopkins University School of Nursing, and I think that we have to start with policy that is values-based and also informed by evidence. I think that currently we are in the checklist era of maternal health action, and hospitals, other institutions, clinics, legislative bodies are focused on what can we check off rather than really creating policy that is values-based and based off of research. When I say values-based, it means that policy that affirms that Black women are fully human and fully worthy of compassionate, quality care. When I say evidence-based, it means that we have a lot of research around potential solutions. We have many studies that uphold that midwifery care is safe, that for a low-risk woman or birthing person, that midwives can actually produce enhanced outcomes when compared to physicians. But here in the United States, we have relatively few midwives. When we look to, for example, Europe, women, birthing people in Europe have as much as 7 times more access to midwifery care. Midwives are the first line of maternity care in Europe, but they have better outcomes than what we have here in the United States. So I want us to think about how we can really redesign care by thinking about our maternity workforce and what policies can be enacted to more fully integrate midwifery care, produce more Black midwives for more racial concordant care, and think about how we can reduce barriers to midwives practicing in hospitals, birth centers, and home settings as well.
Thank you all so much, and just want to remind us that in order to have values-based legislation, we need legislators that have those same values. And so I want to thank my colleagues again for those who took the time to be here today, and we take note of some of the missing voices in the room. Dr. Jeffers, we'll stay with you. And as we mentioned, your work centers on reproductive justice lenses to examine the structural and social determinants of Black maternal and perinatal health. Can you share a little more about why the reproductive justice lens is so important to drive more equitable outcomes?
So reproductive justice is a framework that was coined by a group of Black women in 1994, and they called themselves the Women of African Descent for Reproductive Justice. And they were really trying to think about how can we center the conversation of reproductive freedom for Black women, not solely on abortion, right? Which is important. We need access to abortion. And yet, when we look at the historical legacy of slavery, Jim Crow, racial residential segregation, we also know that Black women are harmed in specific ways. When I think about Black women's reproductive freedom, I think about forced sterilizations. I think about coercion when it comes to birth control, and really the attempt to reduce Black women and Black individuals in this country. And so reproductive justice calls us to think about the historical legacy and how Black women specifically are harmed when it comes to reproductive freedom. It calls us to think about, okay, if we know why there are these disparities that are happening and that it's linked to slavery, racism, then that means that the solutions that we create, the systems that we redesign, have to address those same causes, have to address racism at all levels, individual, interpersonal, structural, what's happening in hospitals. Reproductive justice is a framework that calls us to action. It isn't just a framework that helps us understand our world, but also produce equitable solutions as well.
Thank you so much. And Kenda, coming to you, as a former chair of the Virginia Doula Task Force, you have been a leader in the work here in Virginia that we've done to increase access to doulas. And so what more would you like to see done here in Virginia and across the nation as far as policies related to doulas?
So one of the policies is that we need higher reimbursement for doulas. Also, when it comes to the healthcare systems, looking at doulas as a part of their care team without having to work for the hospital. I think that's the most important part, and true education when it comes to providers on like the scope of what doulas are truly doing. Birth in Color, we just did a partnership with Virginia Union, so making sure that we continue to invest in our HBCUs because they're investing in their community partners to make sure that doulas are actually heard, to make sure that providers know the scope of doulas. And so when you look at it from that framework, you have different community organizations who've been pivotal in this whole doula reimbursement model. And then when we think about what's actually happening in the back end, you have it where they're trying to put us into a box. And so shout out to great partners like Centera, like Centra, like VCU Health, where doulas are actually recognized as the part of the care team. We are not separated. We're allowed to go into the OR with our patients. And so that needs to be a policy that is across the whole entire state and across the nation so that clients don't have to choose between their doula and their family members.
Thank you. And then Shanice, coming over to you, how is Anthem addressing challenges that patients face in accessing comprehensive maternal health care services?
Thank you. Thank you for that question. Anthem is addressing these challenges by investing in technologies and making sure that our members have access to early and effective care and outreach, having 24/7 availability by partnering with vendors such as Pomelo Care that is able to allow our members to have access to care management and to have access to systems that allow them basically to have a doctor whenever they need it. 40% of care that is experienced is happening after hours. It's happening when the OB offices are closed and when there's no one there to help. Our Black mothers end up in an emergency room, but solutions like Pomelo Care allows for us to have additional resources to educate and to empower Black women. In addition to that, we also allow for the remote patient monitoring so that we can address conditions like maternal hypertension and allow our Black mothers to be able to have that access to check their blood pressure and to be able to check in with their physician timely so that they're ensuring that they're having the access that we require. In addition to that, Pomelo Care does not just address medical, but it also addresses social needs as well. So identifying the mental health needs as well as housing needs and social determinants or social drivers of health, because these ultimately impact the quality of care and the outcomes for Black mothers. So that's what we are doing at Anthem to ensure that we are expanding access to care. We also have a doula network that we continue to expand. There are over 144 doulas, and we have over half are a part of our network, and we're continuing to grow in this manner. So Anthem's on the forefront of making sure that our Black mothers are receiving the care that they deserve.
Thank you. And then coming to you, Dr. Price, 98% of births in the U.S. happen in hospitals. What hospital or industry redesigns are needed to address the higher maternal mortality rates for Black women?
Thank you. It's a great question. And one of the things that we need to do is acknowledge that there's an issue and make a commitment to eradicating health disparities. That's the first step. And that needs to happen across the entire healthcare industry. It's very easy when you wake up in the morning as a healthcare provider to say, I'm doing a great job. I have every intent of doing great things for the patients I care for. But when the reality is that those outcomes do not reflect that mindset, we have to be very committed to saying something is not working. And so what healthcare systems need to do is actually reinvent the wheel. What we tend to do is the same thing over and over again until we get better at it. That works great for a knee replacement. It does not work for obstetric care. Every woman comes with her own story. Every woman comes, with a unique need, and we have to be prepared for anyone who walks into our healthcare system to meet them immediately where they are, provide trauma-informed care. And by that, I mean being able to look at someone and not saying what is wrong with this person, but being able to look at that person and saying what happened to that person, and go in from a place of no judgment. And that is going to require training our physicians differently, working with collaborative care teams that can see patients through different lenses, making sure that our providers look like our patients and that we can relate to one another and very quickly break through those barriers that actually delay care or sometimes result in not getting that right care at all. So we as a healthcare system started looking at what we needed to do differently. We are responsible for 15,000 births a year in the state of Virginia. And where we actually decided to start was with a labor culture survey. We actually did an anonymous survey throughout our entire company to understand what we believe about birth, what physicians think, what nurses think, what everybody thinks, and we saw a great discrepancy. And when people in the same unit don't believe the same things about what they're doing, that's a great place to start and start having transparent conversations around that. The other thing that's a reality in healthcare is that the people who understand this are not in the room when that care delivery is being given. At 2 o'clock in the morning, I'm not standing in that room with that patient when an interaction is occurring that may well have a racial undertone or have a bias included in it. But we as healthcare providers and executives need to make sure that we're building safeguards so that even when we are not present in the room, that there's something in place that protects that patient from the person in the room who may have a bias against that patient. And the way we are doing that now is to actually, within our documentation systems, building acuity levels that are based on what we know about maternal and neonatal mortality. We know which women are at highest risk. And what will happen in our computer systems is when those things are identified, which are unbiased, they just are what they are, they live in the system, the acuity level starts to rise for each risk factor that a woman may present with. Just being Black is a risk factor. Being a Medicaid patient is a risk factor. Having a substance use disorder adds that third level. If you have any history of mental health disorder, that goes up even more. And so as a nurse or as a care provider in that room, when you see a red light flash and it says this is a level 4 acuity patient, you take all of that difficult discussion off the table. That becomes a one-to-one ratio for that patient. And in this way, we can help safeguard every woman who comes into our system. That is where health systems need to start thinking, because we need to collectively take responsibility for the outcomes of every woman who walks into our doors.
Thank you so much. And Nicole, coming to you, your work is focused on community engagement. As one of the first and only independent midwife practices in our community, what policies would make it easier to expand care to midwives and community support?
That's a loaded question. So I want you to think about that map that was up there by the March and Dimes, where those states that are failing, those are states that have the worst midwifery integration. And so Virginia is one of the only states where you have certified nurse midwives, certified midwives, and certified professional midwives that can actually work and see clients. But what I ask is, let us do our job. We are the experts in normal physiologic birth. We have proven over and over, research has shown that midwifery integration into our systems reduce those healthcare disparities. And so I say, help us to increase our workforce, support those pathways, support the programs that help to educate midwives, support building birth centers. If any of you remember the Strong Start, that program where they did studies on these birth centers, those clients, Medicaid clients, had better outcomes than when they went into the hospital systems. You know, also pay us for the work that we do. When we get there, there's no pay equity. As a nurse midwife, I get 100% reimbursement for that global fee, for all of the prenatal care, all of the delivery, all of the postpartum care. And our postpartum care is not just the 6-week visit, it's the phone calls, it's the visits, it's the 24, 48, 2-week, 1-week visits that we do, that we're accessible to our clients. Our other colleagues, the CPMs, get 75% of that. Certified midwives are not even in the DMAS system, so they can't even get reimbursed by Medicaid. So that's a discrepancy. You know, I would also say, let us get credentialed in the hospitals. I had privileges at several hospitals, but because I do not have a supervising physician, I cannot have privileges at a hospital. So I have to get someone to actually be attached to me for me to be able to have continuity of care. If I have a client that needs to go to the hospital, not that they need to go for a C-section or it's an emergency, they may just want an epidural. They may just need some pain management. I can't follow them. I have to go with them as a support person and transfer their care over. Another thing is that we need standard transfer protocols. Those states that had great grades, they have standard transfer protocols. Oregon, Washington, California, New York State, they have transfer protocols where hospital people, community people have a relationship and they know how it's supposed to work. But those are the things that I ask for. I'm not asking for a lot. Let us do our job and try to reduce these numbers.
Thank you all. And for our final question, I'll ask the entire panel in 1 minute so that I don't get the death stare from my colleague. What actions can individuals and organizations take to be a part of the solution and improving Black maternal health? And Dr. Jeffers, we'll start with you.
I would love to see more accountability. I want to see hospitals recognize that being Black is not a risk factor, racism is, that having Medicaid is not a risk factor, lack of access, low income, income inequality, those are the risk factors. Bias towards individuals with low incomes, those are the risk factors. So that's number one. And number two, accountability. We need more systems. When someone dies in childbirth, what happens? It's shrouded in secrecy because of concerns around litigation. But we need more community accountability, more integration with the community, more restorative justice, in which individuals are treated like human beings rather than potential legal cases. So how are we integrating accountability into our hospital care systems? And it's not just about punishment. It's about how can we promote respectful conversations when something goes wrong? Because a lot of times people aren't interested in litigating. They just want to hear what went wrong. Are you sorry? And what are you doing to make it better next time? So I'd love to see more accountability for hospitals and also recognition that the current culture that surrounds birthing care does see Black women as the problem, but it's really the underlying models of thinking, the bias, and the racism that's the problem. Thank you.
Dr. Price.
Yes, I think one of the important things to consider is that healthcare doesn't happen in doctors' offices and hospitals. That is about 20% of where healthcare happens. 80% of healthcare happens in the community. It is where you live. It is what you know, if you have something to eat, it is where you worship. It is where you learn. It is where you play. And that we need to acknowledge that we need to support healthcare where people live every single day and not just focus on the 20% that happens within the walls of buildings. It doesn't end when you go home. It continues and goes on. So resources don't just need to go to the hospitals and healthcare systems. They need to go where people are and meet them in their day-to-day needs. We need to reduce people's stress levels, access, transportation, childcare, and all of those other things that keep people healthy and resilient when they do face adversity.
Thank you. Kenda?
So let's get rid of the check off the box. Yesterday, I was at the Maternal Data Task Force convening that was by the governor's office, and the huge takeaway was ask for aspirin. 50% of clients are already on aspirin, and we still have a huge preeclampsia issue. So let's start there. When a community-based organization creates a program, it works because we're the trusted community organization. It's not gonna necessarily work when you have people that wanna control it and take the program, add all these different things to it, so it's not gonna work. So when we talk about the maternal outcomes and they bring us to the table, they ask us all these questions and we tell them, and then it's like, oh, okay, now we're gonna go over here, we have the funding, we're gonna create the program ourselves and we're gonna do this. And all of the community-based organizations just sit back and look and just be like, oh, okay, so this is what we're doing. But then when we get on the panel and we be transparent, they're like, oop, we're never going to fund you again. And so these are the things that actually happen behind the scenes. So when we talk about, you know, how can we really be transparent? How can we really be collaborative? These are the things that, you know, higher level people need to really understand, that we're community-based organizations for a reason, because the community trusts us. And so they're not going to necessarily go to your organization and say, oh, Kendra, we can't get these people to fill out the survey after we've already applied for this grant. Can you do this? And we're going to give y'all like $5,000, and the grant was $11 million. And so then I look at them and I'm like, no. I was like, are you paying the community for their surveys? Because this is how you're getting your data and this is how you're applying for grants. So if we're going to really talk about the issue, we have to talk about what systems are we going to actually put in place? What are we going to actually do to give back to the community who's given us the patient experience, the patient data? And then also, yes, we can collect so much data, but the patient experience is everything. Just because I have a C-section doesn't mean it was a horrible birth. Just because I have a vaginal birth doesn't mean it was a great birth. And so actually listening to the patient experiences and using that as data as well is what's going to help shape the outcomes moving forward.
Thank you. And Shanice?
One of the things that's extremely important moving forward is that we understand the roles that each other's play in these Black maternal mothers' lives. We have the hospital, and like Amber Price said, that's only a small portion of it. But managed care, we're there too. We have care managers, we have resources that can actually help to bridge that gap. Sources and solutions like Pomelo and one of our other solutions, concierge care, provides time and provides things that can actually bridge the gap between being in the hospital and being back in the community. Being able to connect our members to additional resources for housing and for being able to connect our members to resources for postpartum needs and most often mental health, having resources that expand mental health. So partnering with managed care organizations and community-based organizations such as ourselves, as Anthem, as a managed care organization, is really key. Because as you said, together, this is how we achieve the goals that we've set out. Thank you.
Nicole.
So I'm going to say that we always have to center our clients in the conversation, right? They need to be centered in the conversation. A lot of times we talk about these systems and everything and, you know, what you're doing, but they're not listened to and they're not centered. Anthem, I love the fact that we have managed care organizations, but if the patients cannot get the Medicaid, they don't have presumptive eligibility, they're not getting the Medicaid until they're well into their second trimester, so they're not being seen, which is a problem. And the other, going back to what Kenda said, is those seats at the table. I'm looking at some of these task force and I'm looking at all of these things that are put in place, but the people who are sitting in these seats are the same people who are part of the problem. They're not a part of the solution. And so why are we still trying to do the same things wrong? You know, if it's not working, it's not working. Let's re-look at, there's that whole transforming maternal health care, right? Coming down from the federal government, HHS, is doing this. But are we actually trying to transform maternal health care? Are we really trying to use the systems and the things that work, looking at the research, looking at the people who are in the community doing the work, the grassroots workers, the community health workers, the doulas, the midwives, who are sitting there, boots on the ground, making a difference, but they don't sit at the table, okay? So those are the things that I would like to see happen.
Well, I definitely appreciate all of the input that we have heard from this panel. And without looking for permission, I would just like to close with a few comments. So as we talk about policy, I would like to remind everyone that is listening and watching in Virginia that early voting has begun. And your vote is a way that you can help some of these policies come to fruition. I would also ask that my colleagues, that we look at the political determinants of health, because then we can look at the role that we as legislators play in either addressing or worsening some of the social determinants that our colleagues here have mentioned. And then those of you that have wonderful ideas for legislation, we have a November 25th deadline for us on our part as legislators here in Virginia to get in some of the ideas that we would fashion into the legislation. So if you think you have a great idea, please make sure that you are reaching out to a legislator so that we can continue to make the change here in Virginia and continue to lead on the issue. Thank you so much. I'll turn that back over to you, Senator Williams-Graves.
So let's give a round of applause for all of our panelists on this wonderful panel, all the information that they shared with us, and for Delegate Marcia Price, who always brings the fire and reminds us that voting is tied to everything. Everything. All right, so here we go. This is where we break out. We have a couple of legislative roundtables. You all are going to go to the second floor. The roundtables are going to be in House Rooms B as in boy and C as in cat. And we're going to, we've got the moderators there, and that conversation will lead us into lunch. lunch. So you all are going to the second floor. You have about 5 minutes to go potty and make it to the second floor. Thank you so much for your time. Thank you for all of the House members and Senate members who are here. You all have a wonderful day. Thank you.